All right, everybody, we'll go ahead and get started. I've got everybody on mute for right now just to reduce background noise. But this is really meant to be an interactive discussion. I'll do some talking and we're going to go through a case here, but I want input on this. And so while everybody's muted now, I may call on some folks and unmute you. Or if you have anything to bring up or talk about, go ahead and feel free to unmute yourself and just speak up, and we can all hear you. I just, with the background noise, I've got everybody muted now, but if you've got a question or a comment, unmute yourself, and I've got the list of everybody in the room, so I'll be calling on folks. Even if it says iPad or iPhone, we'll just, it'll be like surprise. It'll be Zoom roulette on who's on the other line. So thanks everybody for joining. So I wanted to use some of this opportunity to help clarify some things that we've been talking about when we specifically talk about eliciting goals of care preferences with our patients. It's something we use that term a lot, goals of care, and we hear it a lot, but part of the question is, do we really know what that means? And not only do we know what that means, but more importantly, do we know really how to help patients figure that out? Do we know how to have some of those difficult conversations to elicit those goals of care? Because that's not easy, as we all know. Generally, if you ask a patient, what are your goals of care? They may know a little bit about what you're talking about, but a lot of them won't. And they need help doing that. So when we talk about goals of care, really we're talking about what are the patient preferences and values that really should be the primary factors in determining what treatments or what care plan that the patient should have in order to keep those preferences and values intact, right? So, it's eliciting what's important to patients, because then that drives what theoretically should be the best care plan, the best treatment choices, what to do, what not to do, what stage of care are they in, what treatment stage are they in, and what program, in our case, palliative care versus hospice care, what program is the right program for that patient. The reason we need to explore these is because we're supposed to be the experts in that, right? So this is really part of the reason why we are called upon to consult on patients, or we're referred patients to us, not only to help with their end-of-life needs, but also to help patients clarify those goals of care. And we should be experts in those, but it's not easy to do that if you don't have a lot of experience with that or a lot of practice with that. But when we think about palliative care as a specialty and hospice as a specialty, this is part of why we're asked help to care for these patients. If you think about it, if you consult a cardiologist, you're really asking for that cardiologist expertise on what are appropriate treatments for that cardiac condition, what are appropriate medications, what are appropriate procedures, what's appropriate advice for that patient, and it's all really meant to be tailored to that patient specifically. Same if you consult an endocrinologist, you're really asking for that expertise in, say, diabetes care or thyroid care. And it's this exact same thing when palliative care hospice is consulted. They expect us to be the experts in what we do. They want our opinion. They want us to help patients. So it's not simply just to go in and help give medications or help hold hands and help follow that patient through their journey. And all those things are important. But one of the biggest things we do are help to determine what these goals of care are, elicit these goals of care so that we can help the patient figure out what's best for themselves. Of course, in addition to that, we do symptom management. We do education on disease trajectory and a number of other things that we are meant to be experts in. But specifically when we're talking about this, when we're talking about goals of care, it's important because again, we use that phrase goals of care, but it's important to know exactly what that means. But even knowing what it means, describing what I did earlier, sometimes it's easy to assume that patients should just automatically understand what their own goals of care are. That if we're evaluating a patient and they're on a certain treatment path. So we're evaluating a patient with congestive heart failure and they're going down a certain trajectory. If we're evaluating a patient with stage 4 lung cancer and you see that they're going down a certain trajectory, we can't assume that they understand that trajectory, and we can't certainly then assume that they understand all of the risks, all of the benefits, all of the ramifications of whatever treatment plan has been put before them, because we all have seen where other consultants, other specialists, cardiologists, oncologists, other healthcare providers, a lot of times put out a treatment plan, but it's really not always tailored to what's best for the patient. So that's for us. For example, if we've got an end-stage heart failure patient who we're seeing, they've been in the hospital 3 times in the last 2 months, and the patient has poor symptom control. They're on 18 different medications and 18 different supplements. It might be easy to assume that since this patient has been in the hospital and been through all these things, that this patient automatically understands his prognosis, and that prognosis is probably poor, and that he is on a downward trajectory. And we may assume that since he's been in the hospital 3 times in the last 2 months, that he's fine with going back to the hospital again and potentially dying there. But we can't assume that the other healthcare providers that have taken care of him so far have approached that with this patient. And that's part of our job, to discuss those goals of care. And even if the patient has been to the hospital for 3 times in the last 2 months and says, yeah, I guess I'd go back to the hospital again, we can't take that for face value. We have to really approach that and figure out, does this patient understand what these things mean? Do they understand what going to the hospital means? Do they understand what still being on these medications mean? Do they understand what being a full code and having CPR means? And those kind of things. So that's what we have to help determine, because if this patient, if his goal is to live absolutely as long as possible, no matter what type of quality of life that he has, and is fine with dying in the hospital and understand what that looks like to die on a ventilator or after a failed code, then that's fine. We've done our job and we've helped inform that patient of risks and benefits, and we've let them make that decision. But a lot of patients may not make that decision, but they need to know those choices. So if this patient's goal is to have as much quality of life as possible and die at home comfortably with his wife and children at his bedside, then he's definitely not currently on the best course of treatment for that. But cardiologists, ER physicians, hospitalists, they don't always recognize that and discuss those options, and that's what we're there for. But again, it's not easy. So how do we do that? And how do we bring up those conversations? And this is where we get to play a little bit of psychologist and all, and that's not easy to do. So what these presentations do is help to use some phrasing and some terminology and some techniques that you can use when you're talking to a patient to help elicit those things. And so what this presentation first it will do is clarifying goals of care. It'll walk us through a patient who is a COPD patient, and it'll help us to look at what the patient is actually saying to us and using those things that the patient is already telling us to further elicit more information, and using some of those techniques too. And as all of us know, if we've tried to have those conversations, there's a lot of different right ways to have these conversations, and there's right things to say, but there can be many right things to say. There aren't very many wrong ways to say things, but there certainly can be ways that are less effective or that could be done differently. But it's definitely an art form. Just like anything, it takes practice, and it takes using some of these techniques and phrases and adapting them to your own style. So, picking things up here and there, listening to some phrases, listening to some techniques, and deciding what works for you. Because I've certainly heard things said that or taught that you just say, that's just not something that you would hear me saying. That just doesn't really fit with the type of language I use or type of phrasing I use, and that's okay. You pick things up and you tailor them to your own style. So this is the first step. My hope is that we can use these and work on some more specific areas of goals of care. So this is a general presentation on working through this patient on using some of those techniques, but there's some more specific courses that can be used to work on advanced directives and CPR, how to have a family meeting. And so we can certainly do those as well to kind of build on this. While we're talking about these things too, and I'll talk about this again at the end, but when we're discussing these conversations with patients and how to elicit information and what's important to them, the other key thing is always make sure that you're documenting those things. Some of us have a really good job of having these conversations and pulling information out, but if it's not documented, it makes it really, really difficult for somebody else to come along and understand what's going on. So documentation of these things that we're discussing is almost just as important as having these conversations. Okay, so we'll start with our presentation here of this patient. This is where I'm going to call on some folks. So everybody wake up if you're dozing off. If you're driving, tell me you're driving. If I'm calling you, don't drive and talk at the same time. So this is Javier. So Javier is this patient. Let's just, for this sake, we're seeing him either as a palliative patient or as a new referral and assessment. But we've gotten his information, and Javier's 75 years old, and he has COPD. He's also got hip pain related to long-term steroid use because he's been on steroids for long-term for his COPD. So that right there tells us that he's had COPD for quite a while and could be in a severe stage. So he's had multiple hospitalizations for shortness of breath, including hospital admissions, and he's also been put on a ventilator previously. So this says he's in our office, but we don't have an office. So we are in Javier's living room, and we're talking to him there for this visit. So we're going to begin the conversation. So again, I'm going to call on some folks to fill in these blanks, and there are no right answers. There may not be wrong answers. There may be answers that we laugh at you for, but that's okay. We're recording this too so that we can put this on the web later for those who couldn't attend. But really just give it your best shot. I'm going to call in a few people for each of these just so we can get some different ideas, and then we'll go through some tips. So you ask Javier how he's doing, and the first thing that he says is, "I'm not sure I can keep going like this." So let's see who we've got. Tamara pops up. I'm going to unmute Tamara. Can you give us an example of what you might say first thing to this patient?
I'm driving. What, can you read it to me?
So he says, "I'm not sure I can keep going like this."
So I would ask him to kind of define what like this is, like what's been going on
Okay.
lately.
Okay. Perfect. Who else do I got? Bethany.
Yes.
What would you like to respond with or say to Javier right now?
Maybe an open-ended question, something like, how would you like it to change? Or what things about like this, this situation, kind of searching for his goals of care.
Okay.
Wishes.
Yeah, great. Thank you. And let's see, one more. Heather pulls up.
Can you hear me?
Yeah.
So I think it's definitely trying to have a little bit more background information. I think both of the answers they were talking about kind of even with like kind of piggybacking on the open-ended questions, trying to gather more information to kind of have that better understanding of his goals of care. So with that, I kind of would just kind of go over things that have been kind of more going on with him lately, how he's been feeling, even just kind of just overall mood wise, in a sense of kind of just identifying, kind of even maybe just clarifying with him what he means when he's saying that he's not sure if he can keep on going on like this.
Okay, great. Perfect. So, yeah, all good answers there. And we'll check off of this.
Brian,
So,
can I just,
oh,
Brian,
go
can I
ahead.
just jump? It's Mate.
Hey, Mate.
Thanks for inviting me, and you know I've always got something to say.
Sure.
But I guess something like this, I think a good answer could also be silence. You don't need to say anything.
Mm-hmm. Yeah.
So using that power of silence to be able to say, when he says, "I'm not sure I can keep going like this," obviously the attentive listening and the body language, things like that, but then also just sitting there in silence and being okay with that. Because sure enough, you know, in a few minutes he'll come up and just say, "It's been really hard," or "My wife's worried about me," etc.
Right. Yeah, that's great. Yeah, all good answers. So, yeah, in this case, the expert reply, which I don't know if I would agree that there's one expert reply, but that's okay. We'll go with it. So it says, it sounds like things have been tough. Tell me more about what's happening at home. So in this case, certainly we've responded with a statement and a question. I definitely, like Maite says, I use silence a lot. You know, if you, and some of that I think you judge by a little bit by the tone and by the body language of the patient. If you feel like they just made a statement, but there's more coming behind there, never feel like you have to rush in to ask a question or to make a statement. There's nothing wrong with just sitting and waiting for more, because they may tell you more. So I think that's a great point, that it gives us a reply, and that's what they're asking for, a statement or a question. How do we respond to this patient? But absolutely don't be in a hurry to do that, because they may follow up with more information that really helps. So so here they said, it sounds like things have been tough. Tell me more about what's happening at home. The rationale for this, and this kind of leads into a technique really that can be used for a lot of different cases, situations, statements that patients say. The first part of this, so it sounds like things have been tough. By saying that, essentially you're acknowledging what Javier's saying. So that really right off the bat can be used in a lot of different contexts. So patient says something that may be a little bit vague. You might not understand quite what they say, or they say something that has a lot of impact to it. And you don't want to always just jump in with moving the conversation along without acknowledging what they just said. So something simple. It sounds like things have been tough. Sometimes I'll say, it sounds like you've been through a lot, or just if I know they've been through a lot, I say, it sounds that you have been through a lot lately. And then you ask more information. So I think, it seems like that's what everybody else who gave an answer kind of alluded to, saying, well, we need to know more information. So the one thing you don't want to do is, Javier says, I'm not sure I can keep going like this. You know, what does he mean by that? Does he mean he doesn't want to keep going on living? Does he mean he doesn't want to keep taking his medications? Does it mean he doesn't want to keep going on with you sitting in his living room? You know, it's hard to do, but don't interpret or assume that you know that the patient means something with a vague statement like that. Always find out more. So few answers that are, in this case, good but not great. So in the blue box there, it sounds like we should change the goals of care. So, you know, responding with something like that, and you could interchange a lot of different things. You know, it sounds like you would say we should talk about hospice, or we should talk about your advanced directives, or we should talk about your code status. Those things are important, but they move the conversation along too quickly. They don't acknowledge what the patient just said, and it interprets what they said is something that may not be what they were alluding to. So in this case, he said, "I'm not a quitter." So he might have offended him a little bit there. So that, again, response suggests that you're trying to move the conversation forward, but you haven't understood what their perspective is or what they're coming from. And so in this case, you may be giving the impression that the patient thinks that you think that they're giving up too soon. You mean well, trying to get to those goals of care, but it's forwarding the conversation too soon. Same with the next one, is saying, "I think it's time that we talk about a DNR." That may sound like a good thing to do, and we need to do that with this patient, but in this case, he gets probably a little bit flustered, says, "That's not what I mean. I'm not giving up. I just want to be able to live at home without ending up in the hospital every month." So while it wasn't a great statement, he also just told you a little bit about what he did mean by that statement in that next phrase there. So again, this really brings up the next step in a conversation without actually addressing Javier's concerns, and may conclude that you don't really understand or that you don't really care about what he's trying to tell you through that. So the takeaway from this, make sure you elicit the patient's perspective. Show them that you've heard it. So acknowledge, remember that technique, acknowledge, and then either ask or clarify. So acknowledge their statement and then ask for more. And again, remember, don't be in any rush to do that, because like Maite said, silence is always an acceptable response to something like that. And when you do that, like it says in the blue box, explore those values. It helps create that shared understanding. So it's really your first step in building rapport with that patient. All right, so you just ask a question, try to get more information. Now Javier says, "My son told me to ask about a lung transplant. He knows I've always been a fighter." So again, a statement that could have a lot of meaning to it. Amanda, I'm going to unmute you. What would your next first statement to Javier be? She may be working. Okay. How about Jessica? Be working too. Kristen?
Can you hear me?
Yeah, there we go.
Okay.
Thought I was dead to the water for a minute.
Of course, this is the one you got to pick me on. I'd probably ask, if he's, like if his pulmonologist has ever mentioned this to him, or, try and find out more information about if he has more info, or if we're kind of starting from scratch, like his son told him to ask about it and he wants us to take the ball and roll and see where it goes.
Okay. So kind of try to see what he's been told in the past. Val Criswell, are you on?
I am on. Can you hear me?
Yes.
I was going to say the same thing that Christian just did. Just getting more information about if that's even been a topic of discussion with his doctor, and kind of how much information he has on that.
Mm-hmm. Yeah. Great. Okay. All right. Thanks. Yeah, I agree. I when given information like that, or sometimes even not given information like that, a lot of times when I'm seeing a patient for first time or follow up, asking what they understand about that. So kind of turning it back around, what have other doctors told you? What do you understand about your condition? In this case, really kind of a similar answer to that. So first thing, certainly in this reply, was that acknowledging that first step. So just saying, it sounds like you, Selena, I'm guessing that might be his wife, and your son talk about your COPD. So that's great. Tell me what you've discussed in the past. So in this case, you're eliciting more information, not necessarily directly about what other physician might have told him, but what the family's discussed. And I think that could lead into a discussion about what they've been told from other physicians, just to decide what does the patient think about that. So he said, my son told me about this, but what do you think about it? So in this case, rationale, just first you understand, you acknowledge what the patient is saying, and then he responds after that, says, I told him I don't want to be in the hospital anymore. Every time I leave, I feel worse, and it's a burden for my family. So pretty big statement there that kind of leads into the next scenario or next question. But let's look at a couple things, good but not great responses. So saying, maybe you should talk with your pulmonologist about further treatment. I can get you an appointment. So again, that may be part of the conversation at some point, but you really have furthered that conversation, and you really didn't explore what he means by that, or what he understands, and didn't acknowledge that first statement, didn't really acknowledge what he's saying, really just kind of jumped to a conclusion that he must want to know more about the lung transplant. So also suggests that that maybe I've taken sides in that disagreement, or saying that, oh, maybe I agree with your son and you should look into a lung transplant, which doesn't really do much to further the rapport with that patient. The other thing is trying to give an interpretation or an opinion, or a conclusion on in this case really probably on prognosis too quickly. So given your condition, it's highly unlikely that you're eligible for a lung transplant. So probably true information, but probably too soon in the conversation. Like I said, it's technically correct, but it really didn't address the emotional context. So, and that's part of just listening. That goals of care is listening to what the patient's saying and really trying to interpret what they mean, which you don't always have to interpret. You just ask more questions. And so when in doubt, always ask more questions, or silence to see if they'll give you more information. But that's a tip too. If you get stuck when patients say something that might be difficult or emotional, and you don't really know what exactly to say in the moment, either don't say anything and just be quiet for a minute and see if they say anything else. But also you can just turn it around and ask another question and just tell me what you mean about that. What do you think about that? That's one of the easiest way to really turn it around in a non-confrontational way and get them to tell you more. So, and this says takeaway number 2, invest time in the beginning of the conversation to understand those values and understand the relationship. Because in this case, he's giving you some information indirectly about what that relationship is with the family and with caregivers. So if you just focus on, you mentioned the lung transplant, you may be discrediting that he's also giving you some information into the family dynamic there too. All right, next one. This is a tough one. So Javier says, I don't want to be a burden to my family. Let's see. Anthony, are you there?
Yeah, I'm here.
Hey, Anthony, what would you like to say to this gentleman?
Well, probably just kind of getting a feel for activities of daily living and things like that. And, in what ways do you feel like you are a burden to your family right now? Who are you living alone? Do you have family that lives with you or cares for you? What can you do, and what do you feel like you're dependent on them to do for you that you don't want to be?
Okay. Yeah, great. So kind of getting more information into what the patient's functional status is like by using that is good. Mary? Is Mary there? She's probably working. Millie?
Oh, see, this is a hard question for me because I never know what to say when somebody says that.
Mm-hmm. It's a tough one. I mean, there's a lot in that statement there.
Yeah, so I think I always have to go with what Anthony said is, how do you believe that you're a burden? What makes you feel that you're a burden?
To what makes you feel that way. It's kind of a different approach to that too. So good, thank you.
Or have you discussed that with your family?
Okay, yeah. Have you discussed that with them? Yeah, find out what they mean. Let's see. Some people don't have audio. We gotta get one more. Oh, it's random iPad that's unmuted. If you're unmuted, find out who it is.
That's me, Stephanie.
Hey, Stephanie.
Hi. I'm kind of thinking in the same light as Millie. I mean, when somebody says something like that to me, I always ask, in what way do you feel you're a burden? Whether it's an emotional, they just feel like it's too much for the family emotionally, or like a physical burden, or sometimes an economic burden.
Okay. So let's put what type of burden. So kind of questions along the lines of what type of burden do they think they're being. So, all right. Thanks, everybody. So this reply, again, always, I think it's a good idea to recognize the statement, acknowledge that statement. So in this case, I can see you love your family very much. Maybe he does, maybe he doesn't. I don't know. But something to that effect. That's good. In this case, I agree. I think some way of phrasing and eliciting more information. Essentially saying, what do you mean by that? What do you mean when you say you're a burden? Kind of not in a confrontational way, but just in a compassionate way to try to elicit more information about. Yeah, I think everybody's right there. I mean, by that you can really elicit what their activities of daily living are, what their functional status is, what their needs are, in all different ways. So you could really pull a lot of information by acknowledging that statement and delving into it. In this case, this one kind of highlights another technique that this reply has used, that statement by acknowledging it, but then also turning it into kind of, this one really does try to further the conversation by asking permission. And I think if I remember right, that's the takeaway from this is to ask permission to move on with the conversation. So in this case, I can see you love your family very much. Would it help if I tell you what I'm seeing with your COPD so that we can talk about options and what options might be the best for you and your family? So again, I like that statement. I think it's good to ask permission to bring up new things, but I think I agree with everybody else saying you need to find out some more information about what specifically he means by being a burden, and finding out how that ties into those goals of care. Good but not great answers, and this highlights something that I think can be easy to do. That with an emotional statement like that, it gets tough. And if it was a friend or a family member or it's somebody that you really were close to on a personal level, and they said that to you, you'd be really tempted to try and ease them and try and make it better, kind of fix that, when they say something like that they think they're being a burden. So in this case, saying your family would never think you're a burden, and that's probably not the best answer, just because it shows empathy in this case, but it doesn't really move forward, and it really doesn't elicit anything more, from information. So, and that could be tied into a lot of different statements from patients that, whether they they're kind of frustrated and they either taking it out on family members or caregivers or other doctors, and it can be easy to try to want to side with the patient and make them feel better, but be careful not to jump to that too quickly. COPD is a very tough illness. Again, that kind of doesn't really move things forward, and it also reinforces that the patient probably is a burden. Really, just kind of, even though it is a pretty vague statement, may not seem like it's doing any harm, but it really might make the patient feel like that he's more helpless. Have you considered hospice care? So again, this case that, it may be appropriate, and probably in this case it is appropriate, but it's probably a little too soon in that conversation. You're jumping ahead to that clinical recommendation without really exploring those values. So you haven't really yet, even though he's giving you a lot of information and you kind of see where this conversation probably should be going. He doesn't sound like he's excited about going to the hospital anymore, doesn't want to be a burden on his family, so needs extra help in the home, probably needs some symptom support, but it really hasn't pulled all that together to jump quite into just saying, if you consider hospice care. Now, I think, in this case, if you used the previous, if you acknowledge that statement and said, it sounds like you love your family very much, would it be okay if I made a statement, or would it be okay if I made a recommendation based on what I'm seeing? And that can be an opportunity to introduce hospice care if you feel like you're at that stage of the conversation. It does, and I think this does that. It just, so the takeaway on this too is asking permission. So I think that's a good way to kind of ease some of the harshness of some of these conversations, is instead of kind of assuming that it's time in the conversation to discuss hospice by stating that, ask permission and kind of piggyback that off of something that the patient might have said that leads into that conversation. I think you could do that if they're talking about treatments that aren't working well anymore, or side effects from treatment. If they're going through chemotherapy that has a lot of side effects and you get the impression that they're really tired from it, but they don't want to give up because they feel like they'd be more of a burden on their family. Things like that, things that the patient says, you can use these techniques in almost any part of the conversation when they give you that information to go off of. There's one more. I know my family wants me to be aggressive, but I can tell things aren't getting better. I just want the time that I have to be good. So first thing I say when I read this is like, ding, 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 here we go. Call Dr. Smith, get the orders ready, get the assessment nurse on the way. Here we go. We're ready to admit this patient to hospice. And he really is giving you a lot of information there that, you're in this statement, it sounds like the patient is ready for hospice, but now it's all in your approach. So I think this last group participation question, let's see, Lisa?
Yeah, I think that I would probably start with what does that time being good look like for you?
Mm-hmm. Yeah. So, I'll just say, what does that time look like for you? Yeah, I think that's great. If I could type. Good. Okay. Mark, are you there? Maybe not. How about Maite? Yeah. Add something to this one?
This one's a tricky one, isn't it? I think,
yeah.
I would ask around what's his hope for the future, in terms of, he knows that things aren't getting better. So what are you hoping for? And when he says that he wants the time that he has left to be good, I'd also try and ask something around like a prognostic question. What's your sense? Or as Tim talks often around is, what's your little birdie telling you?
Mm-hmm. Yeah.
Which he's essentially told us that, I know my family wants to be aggressive, but I can tell things aren't getting better.
Yeah.
And talk a bit about like aggressive symptom management and, aggressive ways to be able to get you comfortable and enjoy that time that you have left.
Mm-hmm.
So what are we being aggressive about as opposed to, ICU, intubation, full code, all of those sorts of things, but shifting that focus to what the aggressive treatment would be.
Yeah, I think so. I think, all those answers are great. I think, what that initial, what Lisa said, he says, I want the time that I have left to be good. So what does that look like? I mean, that's a perfect segue into goals of care.
Right.
And then, he says, my family wants me to be aggressive. So that is a good opportunity to maybe address, even if the family's there, ideally to say, well, what's aggressive treatment look like? I think, we talk about that, and I guess I'll sort of be tying some of this into what I was going to talk about with documentation. The patient's given us a kind of a perfect lead into being able to describe what aggressive treatment is. And I see that a lot in documentation in a lot of different arenas of palliative care and hospice, is saying, well, patient still wants aggressive care, or patient's not of hospice philosophy, aggressive treatment, but really doesn't outline, specifically what does that mean. So
what is it? Right.
Yes, yeah.
And
so
also here, a question that someone had said for one of the previous questions was, have you had this discussion with your family? Do your family know what you want?
Mm-hmm.
If there comes a time that you're not able to say what you want, and then you can start talking about advanced care directives and power of attorney and things like that. Who have you nominated? Would they know that you don't want aggressive treatment?
Sure. Yeah, great.
He's opened up a can of worms for us, which is helpful.
Yeah, it is. It's a tough, it's a lot in that statement that you could go in different directions and maybe make it a kind of a multi-part conversation depending on how things go. But
right, which Kristen's written in the group chat saying you need to ask about family as well. A lot of people will continue aggressive treatment because of family and might need a family meeting. Yeah, super good point.
Yeah, definitely. Yeah,
I don't think we utilize family meetings enough.
Mm-hmm.
And I think we often talk to the wrong family members. You just assume because the wife's there that she's the power of attorney or the decision maker, or the son's sitting there that he must be the most supportive son in the world. And quite often it's not the case, that the person that's sitting with them in the hospital bed or visiting them at home, it might not be the person that we should be having the discussion with. So, no, good point.
Yeah, exactly. That's a great point. So this reply, really kind of brought a little bit of all those together. So yes, we're at a point where things have gotten worse. So kind of making a statement to acknowledge what the patient just said. And then could you tell me what a good day looks like? So yeah, that's kind of specifically, I like that too. What does a good day look like, or what does your best day look like, so that we can help you. It says, so we can try to get there. I think that's, so we can help you try to see what that looks like. Something like that. Good, but not great answers to that. So great, we'll try to make that happen for you. So that's one thing I think, agree, probably, even though the patient's basically just told you that they are ready for hospice in your mind, and you could easily interpret that, but don't jump to the conclusion and say, okay, I've got consents for hospice here in my pocket, so let's do these. So kind of tease that out, show some empathy. This response here validates his wishes, but it's just a little bit premature. Still want to tease out those values and goals a little bit more. You said that you're a fighter. We don't have to give up now. I don't really understand that. I guess you're really just trying to make the patient feel better. And sometimes that I guess that can happen too. If a patient says something that seems a little bit like they're losing hope, or like they're feeling defeated, human nature is to want to encourage them and say, no, you're doing okay. And I think us physicians are just as bad as that as any, because you want to help people feel better. You want to treat people. And so, but it's just not always the right thing to say. So you don't have to take away all their hope, but at the same time, they want to be realistic about where things are at right now. So, and this even says the clinician's response may undermine Javier's trust because it does not acknowledge what he's already said about what's important to him. So takeaway on that, explore what matters the most. And we talk about that a lot too, what matters most to the patient, and make those recommendations. I'd say ask if you can make those recommendations, and don't jump to those things prematurely. Just keep, like I said before, just keep asking questions until you really understand what's important to the patient. So, oh, there's one last one. I'll go through this quickly. I want to spend as much time at home with my family and grandchildren as I can. They are the most important things to me. So one last round. Sarah Roulette, which is this?
Hey, it's Sarah.
Oh, it's Boss Sarah.
Hey, hi. Hey, I had raised my hand just for the last one because
Oh shoot!
you were talking. Oh, can you hear me?
I can hear you. Yeah, sorry, I didn't see your hand on.
Oh, sorry. Hold on 1 minute. Digital GFI. Hold on, I'm gonna get on the other call. All right. So sorry, I'm got two phones up to 2 ears here. I guess that's why we have two ears. But anyway, I wanted to just mention on that last discussion with the statement of the patient talking about hope. You know, I've always found it to be beneficial just to sit in silence, like Mai Tai talks about, and make the statement that sometimes hope changes, and let that sit for a little bit and absorb, because I think that's true in that sometimes you have hope for a cure, and then you get to a point where you just hope for peace. And, you know, as they sit and absorb some of that, a lot of times that'll come out in their statement back to you. But anyway, okay, so Javier says,
Absolutely. No, that's a really good point, Sarah. That's fabulous, because it's about defining what we're hoping for, right?
Yep.
Well done.
And I think too is that patients can't recognize that, and sometimes family members can't recognize that when they're far, far away. You know, if you're in California and your loved one's in Kansas and they're dying and they haven't seen that process, to be in California and then come home and visit, it's a real shock to the system. And so 9 times out of 10, you're doing a lot of those types of discussions with families that come in and have that shock to the system, and then you talk about that. But anyway, point being, okay, I want to spend as much time at home with my family and grandchildren. They're the most important to me. All right, my first response is, that sounds great. What does that look like to you? Okay, I'm going back to GFI.
All right, thanks.
Yep.
Right. Amanda, are you there? I called on you earlier. Nope, still working. How about Angie? You're next, then, or Amanda.
Okay. I definitely think just what she stated of what does that look like to you? What maybe does it look like in relation to your medical care? And so kind of that leading into sort of explaining, you know, the differences of what, you know, the hospice versus, you know, continuing to see a doctor in the community, but something along the lines of, in terms of your medical care, what does that look like? And
Yeah, that's good. Kind of along the lines of that last question of saying, you know, what does that look like for you? So you want to spend as much time. What does that good day look for you? And yeah, perfect opportunity to kind of lead into specifics of care and matching that to what service lines there would be, or what treatments there would be. So great.
Kind of tell him that you're on his side, that you want to help him. That you're
Yeah. We are on your side. Yeah, definitely agree with that too. Kind of can certainly use that in a lot of these discussions to make sure the patient knows they're not alone with any of these things, that we're there to help. So perfect. Okay, get through these. A couple of things quickly. Yeah, I think we should get you some help at home. Not a bad statement. It just kind of jumps to that solution without actually acknowledging the statement or the permission. That makes sense. I know how important your family is to you. Empathetic, it's not a bad statement, but then you'd have to follow it up with something else, another question, because it misses that opportunity to ask permission to give your recommendation or to lead into that discussion. So takeaway number 5, ask permission before you make a recommendation, and explain your recommendation, how that basically ties into what the patient's already explained. So I think that's a good point too, to use things that the patient has said to tie in to what those recommendations would be. So if they've talked about, I want to be at home with my family, certainly a good tie into how hospice could help you stay at home with your family, those kind of things. So wrapping up, which takeaway was most surprising? I don't know, this is just a subjective thing. We'll just pick one. Yay, try it out next time. Try all these things out, and I'll send this out to everybody. There's a couple different little tools that go along with this. Actually, I pulled up here. Some communication phrases. I know this is probably hard to see on the screen, but I can send this out too. That this actually gives some specific phrases to respond to emotion or respond to different things that patients might say. And then it uses that in a specific context. So over on the right, using that in context with advanced care planning, or using that with determining decision-making capacity, giving prognosis, breaking bad news. So there's some good phrases, and I can send that out too. But I think it'd be good too. There are some courses and cases that go over specific scenarios like that too. I think this was kind of a goals of care conversation 101, so to speak, to help just learn some of those techniques, and just how to feel a little bit more comfortable in those conversations, and how to navigate those a little bit better to gather more information and be able to tie things together. And and then last, I think I said before, we have these conversations, we have good conversations with these with patients that elicit this information, and it may go one way or may go another. But one of the keys is making sure that you document that information and not just be super general about it. If you're having this conversation and it goes the other way with Javier, and he says, nope, my family's right, I want a lung transplant and I want to do everything I can, and take me back to the hospital. That's certainly the patient's choice, but make sure you document specifically, what kind of things that led to that. What kind of things did you discuss with him that led to that? Because otherwise it can be difficult to understand how that information was gathered, or how you determined that the patient really did want that. And again, you don't have to have a word-by-word dictation of your conversation with the patients, but whatever the avenue is, whether it's an assessment as an assessment nurse, whether it's an initial palliative visit, whether it's initial consult in the hospital, or whether it's a visit as a hospice nurse that patient's contemplating going back to the hospital, or resuming treatment. Learning how to have these conversations, but then also documenting to where everybody knows that they know what the goals are to the patient, so that it's clear for everybody. Now, just kind of in closing, since we're about to an hour here, I'm going to unmute everybody just to see if there's any other conversation or comments. I guess while I'm doing that, Maite, do you have any other additions or last words?
I think so. These have been great. This is a really good learning tool, and there's loads of resources out there around difficult conversations and how to respond to that. So I can flick some of those out as well. I might send them to you, then Brian, and then because you've got everyone's email address. So
Okay,
Yeah, it's great.
perfect. Sarah, anything you'd like to add in closing? Oh, she might be tied up. This is, I think I also, if I did it right, this is also recorded, this whole session. And so I'll figure out how that works and send it out if there's anybody that you think this might benefit, or other staff can check it out in their own time. But hopefully if this was helpful, we could do other periodic kind of discussions and presentation like this, since this format kind of works to be able to just took an hour and nobody had to congregate in one place. So thank you everybody for joining. We'll let you get back to your day and hopefully do it again soon. All right, take care.
Thank you.
Thank you, Dr. Davis.
Bye.
Bye-bye.